Hello, everyone, and welcome to the TMA's Ask the Expert podcast series. Today's podcast is entitled Understanding Acute Flaccid Myelitis. We are a nonprofit focused on support, education, and research of rare neuroimmune diseases. You can learn more about us on our website at myelitis.org. This podcast is made possible in part through the generous support of Alexion Pharmaceuticals Incorporated. Alexion Pharmaceuticals is a global biopharmaceutical company focused on serving patients with severe and rare disorders through the innovation, development, and commercialization of life-transforming therapeutic products. Their goal is to deliver medical breakthroughs where none currently exist. It's driven by the knowledge that people's lives depend on their work. This podcast today is being recorded and will be made available on the TMA website for download via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar. Today, we are pleased to be joined by Tricia Plum, who will be moderating this podcast. Tricia is a senior research nurse for the neuroimmunology team at UT Southwestern. She graduated with her bachelor's and master's of science in nursing from the University of Oklahoma with an emphasis on acute care for pediatrics and adults. She moved to Dallas specifically to be involved in clinical research for the pediatric population. In December 2013, she joined the UT Southwestern Neuroimmunology team. She educates nursing staff, patients, families on the value of research, along with coordinating various research studies highlighting pediatric demyelinating disorders. She completed her certification in rare neuroimmunologic disorders in July 2015. So thank you, Tricia, for moderating today.
Thank you, Erin. It's a pleasure to be here. And thank you to the TMA for giving me the opportunity. And I would like to introduce you to Drs. Benjamin Greenberg and Karen McCain. Dr. Greenberg received his Bachelor's of Arts degree from the Johns Hopkins University and his Master's degree in Molecular Microbiology and Immunology from the Johns Hopkins School of Public Health in Baltimore, Maryland. He attended medical school at Baylor College of Medicine in Houston, Texas. Then he completed an internship in medicine at Rush Presbyterian St. Luke's Medical Center in Chicago, Illinois, before going to his residency in neurology at the Johns Hopkins Hospital in Baltimore, Maryland. He then joined the faculty within the Division of Neuroimmunology at Hopkins and became the co-director of the Transverse Myelitis Center and director of the Encephalitis Center. In January of 2009, he was recruited to the faculty at the University of Texas Southwestern Medical Center, where he founded and directed the Transverse Myelitis and Neuromyelitis Optica program. That same year, he established the Pediatric Conquer program at Children's Health Dallas. He splits his clinical time between seeing both adult and pediatric patients. His research interests are in both the diagnosis and treatment of transverse myelitis, neuromyelitis optica, encephalitis, multiple sclerosis, and infections of the nervous system. He is actively involved in developing better ways to diagnose and prognosticate for patients with these disorders. He also coordinates trials that have studied new treatments to prevent neurologic damage and restore function to those who have already been affected. And also we have Karen McCain, PT, DPT, and CS. She's an associate professor of the School of Health Professions as well as an associate director of the David M. Crowley Research and Rehabilitation Laboratory at the University of Texas Southwestern Medical College in Dallas, Texas. In addition, she is a director of the Neurologic Residency Program at UT Southwestern. Karen received her bachelor's in physical therapy from UT Southwestern in 1992 and a doctorate in physical therapy from Regis University in 2006. Dr. McCain is board certified by the American Physical Therapy Association as a neurologic clinical specialist. She has been teaching at the university level since 1998 and currently teaches in a DPT program. Dr. McCain maintains a clinical practice with a focus on gait recovery and persons with neurologic injuries. In addition, she actively conducts research in areas of gait recovery after stroke, as well as the impact of arthrosis on gait in persons with neurological diagnosis. Dr. McCain is the principal investigator of an ongoing clinical trial of early standardized task-specific training, or ESTT, in persons recovering from stroke, and has published several papers related to this research. Welcome, and thank you both for joining us today. We have a lot of questions from the community, and we will really try to get to as many of them as possible. So, how about, well, let's just start out with the first question I hear from most of the patients and families. Dr. Greenberg, what is acute flaccid myelitis?
So, Tricia, first let me say thank you to you for moderating, and the Transverse Myelitis Association and sponsors for making these podcasts possible. I think they're a great tool for communicating with our community, not just educating, but hearing the questions that are out there. And the one that you start with, you're right, is one we get on a regular basis. Acute flaccid myelitis. The term was coined for this condition 2 years ago in 2014. And essentially, this is a condition where there is an infection, inflammation, or both of the spinal cord leading to a specific pattern of weakness. So your spinal cord is the conduit of information between your brain and your body. And when we're talking about movement, when we're talking about the ability to move arms and legs, there are several parts to that circuitry, but the two most important are a neuron, or if you like to imagine a wire, going from your brain down into your spinal cord and connecting to a second wire that goes from your spinal cord to the muscle. In the setting of acute flaccid myelitis, there can be damage to either of these wires, but the preponderance of damage is to the second wire, going from the spinal cord to the muscle. The pattern of weakness we see when that wire is damaged is different than the pattern of weakness we see when the first wire is damaged. So when we are treating patients with transverse myelitis, where there is damage to the spinal cord, what we now do is determine which of the variants they have. And acute flaccid myelitis is a variant where that wire number 2 receives the majority of the damage. And people can have loose, floppy, flaccid muscles instead of the tight muscles we tend to see when wire number 1 is damaged.
Okay, fantastic. So one of the other questions that we received is, what are the differences in white matter and gray matter being affected? And are those significant differences in recovery or diagnosis?
So the differentiation between white and gray matter is the pathologic term, the technical term we use to separate out wire number 1 and wire number 2. So when we look at the spinal cord, the white matter houses the wire number 1, the wire that's going from the brain to the spinal cord. And the gray matter is the very start of wire number 2, which is the wire going from the spinal cord out to the muscle. So when we talk about white matter and gray matter damage, we're talking about the difference between wire number 1 and wire number 2. And when you do cause damage to the white matter, wire number 1, the weakness we get tends to come with those tight muscles that I described, the brisk reflexes when a physician taps on a tendon and a joint, there's a jerk of an arm or a leg, those reflexes tend to be brisk. Whereas when wire number 2, or the gray matter, is damaged, the muscles tend to be loose, floppy, flaccid. There tends to be very quick atrophy of the muscles. They tend to get small. The reflexes tend to be reduced. And so the pattern of weakness we see, and then ultimately the rehabilitation techniques that we'll talk about in a moment that we do, tend to be different when talking about white matter versus gray matter damage.
Okay, thank you. I know I'm glad we're recording this, because I know I'm going to have to go back and listen to it over and over. That was a lot of great information. And so I know a lot of things that we get asked about is, what are the causes? And what is the thinking on how the suspected virus attacked the spinal cord? Is it the virus itself attacking, or is this more of an autoimmune reaction?
So that is the proverbial $64,000 question. And the honest answer is we don't yet know. There is evidence to suggest that this is a direct viral infection of the spinal cord. There is evidence to say that this is a viral infection of the spinal cord that then elicits an immune response that causes damage. And there is evidence to say that there is a viral infection that triggers an immune response to subsequently damage the spinal cord. Now, it's a very important question to answer because that will dictate the therapy. And to be honest, at this point, we don't know for sure, but we do have evidence in a number of children that with or without viral infection, the immune system is playing a role. We just don't know to what degree. So when treating patients with acute flaccid myelitis, clinicians and families are put in the situation of having to make decisions about treatment with incomplete information.
Okay. Which brings us to a question we had about treatments, is how do we treat acute flaccid myelitis? What are the potential treatment options realistic for flaccid myelitis and transverse myelitis?
So in the setting of traditional transverse myelitis, where the data overwhelmingly supports that it is a pure immune-mediated event, all of the acute therapy is focused on bringing down inflammation. In the setting of acute flaccid myelitis, we have to make case-by-case decisions based on MRI and spinal fluid. How much of a suspicion do we have that an overactive immune system is causing damage? If indeed we convince ourselves that in that individual case, the immune system is activated in a way it shouldn't be, then we use the traditional therapies that we use in transverse myelitis, specifically steroids, IVIG, plasma exchange. This use has been extremely controversial in acute flaccid myelitis, and indeed the Centers for Disease Control have recommended not using some of those therapies. But when we look at our experiences and the limited data we have, there are some patients who seem to be getting better in the context of those therapies. So we are left at a bit of an impasse in the acute setting, trying to decide whether or not we should use the traditional therapies used in transverse myelitis for patients, particularly children, with acute flaccid myelitis. At our center here at Children's Health in Dallas and UT Southwestern, we have been approaching this on a case-by-case basis to try and decide, given the totality of information we have about any given patient, should we use any or all of those measures in the setting of acute inflammation. Now, once you're outside the acute setting, what is not, in my opinion, being focused on enough nationally is the options from a rehabilitation perspective. Because regardless of the mechanism of injury, whether it's wire number 1 or wire number 2, there are things that should be done to start promoting the restoration of function. And while we may not know for sure if it was a virus or the immune system that caused the damage, once the damage is there are a lot of things that should be done to help the body recover. And so even if we never sort out whether it's a virus or the immune system, and I think we will sort it out, but even if we were never to sort it out, it wouldn't prevent us from developing therapies to deal with the damage once it's done.
Okay. So speaking of a little bit of rehabilitation, Dr. McCain, what role does rehab play in acute flaccid myelitis?
Well, like Dr. Greenberg hinted, rehabilitation is a huge role, because when you've got this abrupt onset of profound weakness, the first thing that you need to do is to, after you're out of that very acute issue and you're medically stable as determined by the physician, we need to get the patient up and see what still moves, basically, see what the weakness pattern is, and begin to try to restore function. And if you follow these cases, that the function varies widely. Some patients have a little bit of movement, some patients have no movement, some patients have almost full movement. But the role of the physical therapist and the occupational therapist and speech therapy, where the role is to get you up and get you into a functional position and see what you can do. So we're trying to restore function from the very beginning. So that means getting you up into sitting, maybe standing if you're able, and my expertise, which is in gait, which is to try to restore gait, to try to get you walking again. So it's to try to restore you to as normal a function as you can possibly get.
Okay, and so I know that it just takes lots of intensive therapies and lots of time, but I do believe that we do see growth and we do see healing. And so I'm wondering if some of the families out there are wondering if there are any specific therapies that they should look for.
So I think there are a couple of things that you touched on there. The first thing is that what I'm looking to promote when I'm treating patients is I'm looking for function. So the therapies that are directed towards functional things are really what's the most important. So I personally spend a lot less time on exercise per se as I do on function. So functional activities, sitting, standing, walking, functional positions. I don't do a lot in supine. I don't do a lot laying down on my back. I like the patients in a sitting position or a standing position. But the other thing that you really hinted on is what we know from the motor learning literature is that learning takes repetition. And learning in your brain, learning in your spinal cord takes repetition. And it's not going to happen if you don't do really what we know from the literature is thousands and thousands and thousands of repetitions. So sometimes I think what we see is that people give up a little bit too soon. They don't get the amount of repetition that they need for learning to actually take place. And when you're dealing with the kind of situation that Dr. Greenberg outlined, which is where that second nerve is impaired, we don't really know how many nerves are innervating the muscles that we're dealing with. So we've probably got really profoundly weak muscles. So we're having muscles that are having to do more than their fair share. So it takes a long time to get those muscles strong enough to be able to do the workload. So it takes time. It takes a lot of time and persistence and patience. And the role of the therapist is to not only do the right therapy, but then provide the right kind of support. It might be a walker. It might be the right kind of seating. It might be the right kind of bracing for the legs, all kinds of things. But that, again, is the role of the therapist to provide those things.
Okay. Are you seeing? I'm sorry. Go ahead, Dr. Greenberg.
If I could just add a comment that there are two words that I hone in on, Karen, as you're speaking, and I really want to underscore them for everyone because I think it starts to be a theme. Early and repetition. And I think the two most classic mistakes we are making in the setting of AFM or the traditional TM that we see in patients is we don't start rehab early enough. Even the most basic of interventions when somebody is still in the hospital, early intervention, the earlier the better, and you're running a study of this on stroke right now, but I think the same paradigm applies to our spinal cord patients. And then the repetition. And I think sometimes it's families, but often it's healthcare systems or even sometimes therapists who are signing off too soon or accepting an outcome too soon and not recognizing not just the global length of time, but the frequency of events that need to occur to coax a nervous system to repair. Right? Some patients will ask me, is it better to do 3 hours a day, twice a week, or 20 minutes every single day of the week? And I always go for the repetition. As much as we can safely do in health, but without days of breaks in between. And I tell my patients, and I'm curious about your thoughts, that you do not by going to therapy, you get better by doing therapy. And that can happen with or without a physical therapist hovering over you.
Oh, I could not agree more. What we tell our patients, in fact, is that therapy really happens at home. The job of the therapist is to structure things. So my job is to get you the tools you need to give you the things to do. I need to see you for the skilled things. I need to help you with the movements that you need, with the equipment that you need, But you need to be doing the things at home that we're doing in therapy. You need to be following up, because exactly what you're saying is right. The amount of repetition that you're going to need to be able to to get motor learning is exponentially more than you could ever do in a therapy session. So 100% agree. It's the amount. Not only is it the amount, but it's that intensity. You can't do it twice a week and think that anything's going to happen. It's thousands of repetitions, so it has to be carried over at home, what we're doing in therapy. Couldn't agree more.
Okay, fantastic. I know that is one of the questions that we see over and over is access to therapies. There are some of our families who are more rural, and some of them are not. But there seems to be some barriers at some point. And do you guys have any suggestions on how they can work with? Should they work with a case manager? Should they work with their physician to make sure that their therapies are not dropped?
Yeah, so I would love we can dedicate an entire hour podcast to navigating the healthcare system to get access to resources that are medically appropriate. That's a really long, nerdy title for a very important subject. And I can impart to families who are listening now or in the future some of the key things we recommend. So number one is starting from the notion that Dr. McCain just espoused quite eloquently, the what I call you don't get better by going to therapy, you get better by doing therapy, and what she described as the role of the therapist is to be the Sherpa, the guide, the coach. But all Olympic athletes do training when their coach isn't around, but they do it the way their coach told them. And so when looking at the resources for therapists, it is actually not as important to have immediate daily or weekly access to a therapist. It's important to have intermittent access to the right therapist who can guide you. And so I would almost rather see my patients have short periods of time spread out over the year with a therapist, checking their current exam, their function, and tweaking their home program, than to do 6 weeks of intensive rehab only to go back to life as usual after that event. So you have to be savvy about the insurance side of things and know that on pretty much all insurance policies these days, there is a limit to the number of outpatient therapy days that anybody can get. You can negotiate with your insurance to see if you can get more. You are best suited to negotiate if you are assigned a case manager from the insurance, somebody you can talk to on a regular basis, and you can ask your insurance company to assign a case manager to your case. If you have a therapist, physiatrist, neurologist, any and all of whom are advocating for your continued therapy through letters or peer-to-peer conversations, and then you strategically use those benefits spread out over a year to maintain a consistent approach. But trying to get more benefits and decrease the obstacles, there has to be some engagement with our third-party payers. And then we encourage people to use whatever limited resources there are in a rationed manner, spread out over the year to get the biggest bang for your buck. And I'll make one other comment, and then Karen, I'll turn this to you. One of the things insurance companies look for, from my understanding, when people are undergoing therapy, particularly inpatient therapy, but also outpatient, is that there is continued measurable progress. And at a point when people, therapists or doctors, document a lack of progress from week to week, insurance companies tend to say we are not going to approve further therapies. The trick with acute flaccid myelitis is, for a lot of our patients, the improvement is happening over such a long period of time at a slower rate that if you take too short a segment, it will look as though people have plateaued, when in reality they're just moving slowly. So I encourage patients and therapists to think about spreading out those visits so they don't artificially record the fact that somebody isn't going to benefit from therapy. Karen, I don't know if you've run into this situation or found ways to handle it, but this is a common theme we hear in the clinic.
No, I think you're 100% correct because as you know from my intro, I primarily treat adults, and we treat adults with chronic progressive disorders, Parkinson's, MS, other things. We have the same issue because we have patients that have progressive disorders, and we have to write goals while we're treating patients that have progressive disorders. So we have the same challenge, a slightly different side of the coin, but the same issue. So we have to write goals that the patient is going to meet even though they have a progressive disorder. So you're right, you have to space out the visits, you have to write the goals so that they're achievable. So you need to be savvy on how to write goals. You need to set your goals that A, the patient can achieve them, and B, you set time frames that are reasonable. And like you say, space them out. And you have to hold your patients accountable. You have to expect that the patient is going to do what you ask them to do at home. We have patients, we give them exercise grids, and we expect them to fill them out and bring them back and show us what they've been doing at home. Because if they're not going to, do the routine at home, then the changes aren't going to be made. So it's a cooperative thing. It's a team sport. Therapy is a team sport. I'll do my part, but you have to do yours. And like you said, you write your goals in a way that they are achievable in reasonable time frames. And I agree with you. You do need an advocate. We write letters all the time to insurance companies asking for more therapy and explain why. We explain how the patient is slowly achieving those goals. We're not moving at the speed of light, but we are slowly achieving those goals. So it does take experience, and it takes a little bit of savvy to know how to write those goals so that the patient doesn't appear to have plateaued.
Fantastic. Thank you both. We've had a few questions. This is more highlighting our younger patients. It is, can you guys think of so quite a few of our patients are under the age of 2 years old, and so getting them to eat dinner sometimes is a challenge. But can you think of a way, or can you think of anything to suggest is like chiropractic care okay for children 1 to 2 years old, or is acupuncture or any supplements, or can you suggest anything for our younger populations?
So you want to take that, Ben?
Well, there's a lot baked into that question.
Yeah, that's a lot.
I'm going to break that down a little bit. Let's just start in general with our patients who are toddlers or infants. When it comes to the rehabilitation, yes, the approaches are different, and there's two aspects. One is just the age. Therapists who work with children that young and even a little older have to be skilled in how to turn therapy into a game. Because as anyone who works with children or has children know, you can't have it be a battle. You have to have therapy be something that they look forward to. I will also say that depending on the age of the child, especially in the toddlers all the way through grade school, we always recommend that after the initial sessions, parents leave the room for long periods of time during therapy, because children will do better working with their therapist without mom or dad around, and then mom or dad should come in at the end. It is hard for parents to do, and I'm speaking as a father, but it is the right thing to do. The children who have had this prior to a year of age, or I should say prior to a point that they were walking, meaning they became weak before they had learned to walk, represent a unique and challenging group of patients from a rehabilitation perspective, because it isn't a skill set they had learned and lost, it's a skill set they never learned. And so what goes into the rehabilitation for that very unique group of children is different, but not impossible. We have our kids who had transverse myelitis and AFM before a year of age who are walking. It took them longer to reach those goals, and they got there very differently, but it is definitely possible. Now, on the holistic approach to care aspect, the use of things other than prescribed medications or traditional physical therapy, things such as chiropractic manipulation or acupuncture. I'll begin by saying at our center, we embrace all of it. We feel as though there are multiple ways that people can improve. They are not mutually exclusive, but depending on the age and the expertise of the practitioner, we may or may not recommend it. So, for example, in the world of acupuncture, I am personally a believer that there are some patients who will get a benefit from acupuncture. I cannot tell you which ones yet, and I cannot tell you the degree, but in general, as long as it is occurring with a light, then I do not have reservations around acupuncture. Chiropractic manipulation is a little different. It is something I am not fundamentally against in any way, shape, or form. I think there are some myths that those of us with an MD after our name are somehow against chiropractic medicine. Most of us are not. There are certain limits that we would like to see. We are not a huge fan of rapid neck manipulations. And for any chiropractors working with our kids who have patterns of weakness or asymmetric patterns of weakness, that practitioner really needs to be comfortable with the neuromuscular population. These kids are different, very different than children coming in with sports-related injuries or strains. And so there needs to be a very honest and open conversation with the practitioner before manipulations occur around what their experience level is. It is possible to do harm in all of these things. It is possible to do harm in physical therapy. And so the practitioner's level of experience is important and should be discussed, but that is on a case-by-case basis. And then finally, you asked about supplements. In general, there are some supplements that we have data to suggest are safe, of essentially little to no data on efficacy, but we are definitely interested in developing it. So we will have patients who are taking vitamin D supplementation if their vitamin D is low. We will have patients who take fish oil, omega-3 fatty acids, some on alpha lipoic acid, things where we have a degree of data to suggest safety, but it is hard to advertise efficacy without the data. And Karen, I don't know if you have had experience with your patients on the acupuncture or chiropractic side of things, and if you want to edit or add to anything with that.
No, the only comment I would have, I would agree with your thoughts on chiropractic. Chiropractic in that age group makes me a little bit uncomfortable, a little bit nervous. I think, again, you'd have to have a lot of confidence in the practitioner. And again, I would caution with respect to the neck. My comments about the walking, I agree with you. We just saw a kiddo in clinic the other day who was just beginning to walk at the time that he got sick. I think that when you're training kiddos who are not walking before they got sick, I think you have to really I think you have to be careful in that population. Certainly those children can learn how to walk, but I think you really need a skilled practitioner to really to facilitate typical walking in those kiddos. I think it's a really critical skill, and I think you need to be careful about how you do it because that motor learning is such a critical skill that you want to make sure that you do it right. Because as you're learning, motor learning is a skill, and motor learning can be either good or it can be bad. You can learn what we call maladaptive behaviors or less than typical behaviors. And we really want to facilitate when you're talking about walking, we want that child to relearn as close to typical walking as possible. So it's one of those skills that's really important. So when you get to that level, it's important to have a therapist who's really skilled.
Fantastic. And so one of the questions we had was about electrical stimulation. Can you talk a little bit about what it is and what we're trying to achieve?
Well, Dr. Greenberg and I are both really big fans of electrical stimulation. We use it a lot. I use it a lot in my adult patients, and I like to use it in pediatric patients, and I've used it lots with pediatric patients with really very, very good success. You have to be a little bit cautious with kiddos because you have to be able to make sure that they can tolerate the stimulus and that they understand what it is. Now, in acute flaccid myelitis, sometimes it's a little dicey because sometimes when you try it, because of the nature of this particular disorder, sometimes you don't get a response from the muscle. Sometimes the muscle is not responsive to the stimulus, which makes it really not a very good modality to use. But when the muscles do respond, we really like it because it really does two things. It stimulates the muscle directly, which helps maintain muscle bulk or muscle mass, which prevents atrophy or sort of shrinking of the muscle. But it also sends signals to the brain and to the spinal cord, which helps that brain and the spinal cord learn, which is a really important thing. That's what we're really trying to do. We're all about motor learning. So it really does two great things all in one. Like I said, it can be a great tool. A lot of times it's one of those things that, like we talked about before, sometimes we try it and we kind of dismiss it before we tried it enough. Dr. Greenberg and I both think it's a great tool, but that sometimes we don't use it long enough. Trying it for a couple of weeks probably isn't going to do anything. I've used it in a child that I treated who had a spinal cord stroke. So she had a similar problem, a different cause, but a similar problem. And she used it really constantly for a year. So I'm talking about long term.
Okay.
But when you do, it's really remarkably effective.
Wow. So you may even be thinking 6 to 12 months, not just 4 to 6 weeks.
Exactly.
Oh, wow. Okay. Okay. Well, I guess each family is going to have to cross that bridge. And but it's really, really good information to know that it's not just 4 to 6 weeks. Okay, fantastic. So one of the questions that I hear pretty often, I would say often, and I would say at least once a month, and this is also talking a little bit about alternative therapies, and it is, how do stem cells have a place in treating transverse myelitis or acute flaccid myelitis?
So the short answer is absolutely yes. So there will be verified, proven, safe, cell-based therapies to improve function after spinal cord events. They are coming. The challenge we face in 2016 is they are not here yet. There are many clinics in the United States, in Mexico, in Central America, in Europe, China, Russia, that will advertise stem cell therapies for neurologic disease. And in general, outside of some really impressive YouTube videos for some patients, we cannot find data or even repetitive experience to show that these are making a difference at a population level. And indeed, we have significant safety concerns around some of these clinics that, when things go poorly, people are not recording YouTube videos to record how poorly it went. And so what is out on the internet is very lopsided and concerning. So what I personally caution and advise families about when it comes to stem cells is to say, yes, we will get there. There are a lot of people working very hard. We would love to have more people working hard. We would love more resources to push this along, but indeed it is moving along. And while waiting for verified and safe cell-based therapies to come, there is a lot of meaningful work to be done. The therapy that is done with people like Dr. McCain and frankly in your own homes every day is not just meant to help recover function, but it is meant to maintain muscle and bone and joint health such that when the scientists do finish the work of safe and effective cell-based therapies, your body will be a good recipient for that therapy. If the muscles and the joints and the bones are ignored for a year or two, I could repair your spinal cord with stem cells, but you may not functionally improve at all because there has been secondary damage done to the muscles, bones, and joints. So I know firsthand and have heard and can empathize with the immense frustration from patients and families on a lack of those cell-based therapies as we sit here in 2016. But I also don't want families to feel helpless or hopeless. Those cells are coming, but in the meantime, there is work that is necessary to be done for those cells to be successful.
Yeah, I completely concur. I think it's just like you said, even if there were something out there, there's so much to be done just to maintain the body, to maintain range of motion and flexibility, and maintain good just general body tonus, things like that. You have to be ready. Your body has to be maintained. So I think your point is so well taken.
Yes, I know that question has come up several times. So I'm really, really, really glad to have that information. Speaking of bone health, one of the questions we had is for Dr. McCain is, are there any malformations or bone growth issues parents should watch out for? And what is the best proactive management they can do for this?
Well, there certainly are, and particularly in the really, really young children. But the very best thing is again, and this needs to be done in concert with your therapist, but the most important thing is to maintain joint alignment. And that's why we have things like standing frames and other devices, positioning devices, splints, things like that, things for your ankles to help you maintain range of motion in your ankles. When joints aren't held in the right position, and not 24 hours a day, but positioning devices that are worn appropriately and worn as they're prescribed by your therapist, then you can maintain muscle length and joint range of motion. And those are the most important things, because joints are meant to be held in a certain position. And when they're not, and when time passes, and when joints are allowed to be held in atypical positions, then bony changes accompany those atypical positions, particularly when you're talking about bones that are not fully formed. Bones that are still malleable and soft are particularly prone to malformation. So just maintaining joint range of motion. And again, standing frames, if your child is not walking yet or not able to walk, standing frames are really important. A device that allows you to stand and be supported. That way you get good alignment in your spine and in your legs and your ankles. It's critical to be able to maintain those positions.
Oh, wonderful. So we have another question about diagnosis, and I'm just going to go back just to the very beginning. I know we talked about what it is, and if the question is, if AFM is an autoimmune response, have we found antibodies to help to figure out that autoimmune response?
To date, we have not. We are looking, and we are studying the immune system in children who have been affected by this. But to date, there's a single antibody that has been shown to be conclusively associated with AFM.
Okay. And then we see some children are testing negative for everything, even just a simple cold. And is there anything we can, even if their child tests negative for everything, we still do everything we can after their acute care for progressive therapies? No change. Okay. Even if they test negative for everything. Okay. Correct.
And one of the things I like to remind people about is, if we put this into historical context, that it is obviously going to be very important from a public health and an individual health perspective moving forward for us to sort out the causes. Very important to do. But if we roll back the clock 60, 70 years during the days of polio, we had no MRI. We had no PCR technologies to identify the virus. We didn't have all the modern technology we have today. And yet, when a patient came in with a certain set of clinical issues, we were able to diagnose polio. And we were able to manage patients, some better than others. We didn't do rehab as well as we should have, if at all. But the diagnosis of the condition today is much more refined because we have MRIs. But even with polio, in some of those cases, we couldn't identify the virus, even though it looked like they had polio. And so, to a degree, what happens after the acute setting, regardless of whether it's virus A, virus B, or the immune system, the approach to recovery is going to overlap or be identical. In the setting of public health and trying to prevent next year's outbreak and trying to give peace of mind and answers to patients and families, we definitely need to determine the cause. But once we are outside the acute setting, a pathway for recovery opens up regardless of if it was the virus or the immune system.
Okay, so one of the questions we have is that many people are concerned. Oh, I'm sorry, go ahead. Okay. Many people are concerned that their child could get acute flaccid myelitis. And there seems to be a misunderstanding that acute flaccid myelitis and even transverse myelitis is an infection, and that it is transmitted from person to person. And is it, do you think anybody can get acute flaccid myelitis or transverse myelitis?
So overwhelmingly, the data tells us that acute flaccid myelitis as an entity is not transmitted person to person. If there is a virus causing this, the virus can move from person to person, but the overwhelming majority, probably 99.999, keep on going for a very long time, % of people will not develop AFM when this virus occurs. And so what we have learned from viral infections of the nervous system for the last 20 years is lots of people get exposed to these viruses. Lots of people get infected with these viruses. Relatively few, remarkably few, come down with neurologic conditions because of these viruses. So why, when you have two children in a household, both of whom have the same cold, the same fever, the same cough, why does one come down with a neurologic illness and not the other? We know parts of the answers, but in the setting of AFM, not all of them. We know from other conditions that part of it's the host, part of it is the genetics of the person who got infected, but the genetics of two siblings are so different that we have not seen two siblings come down with this. And then part of it's the virus. We know that there are mutations that can occur in these viruses that will make them more or less virulent. So one person in a household might have a virus with one genome, and a single mutation in the next person can make the difference. But for the combination of these host issues and the virus issues, the rate of AFM in the setting of cold, cough, flu is exceedingly small. So, speaking as a parent, I have two daughters, and I get concerned every time they get sick. And how many times have we had somebody come in and say, my foot's asleep, and instantly my mind goes to the worst? I remind myself that the rates of these disorders, however devastating they may be, the rates of them are still thankfully exceedingly small on a population level. So for parents who are concerned when a cough or a cold happens, I try to give as much reassurance as I can, because overwhelmingly our kids are going to be okay. And I'll go one step further, because one question we get is about, could this happen again? And I will say, to my knowledge and my experience, there has not been a single case of recurrent transverse myelitis in AFM patients. And that includes after subsequent infection, and that includes after subsequent vaccination. And so we, to date, view this as a one-time only event.
Okay. Fantastic. I know that was actually a question that I hear quite a bit is, will this happen again? Okay. So we have about 8 minutes left. And so let's just turn to some closing remarks. Do you have a take-home message? Could each of you give us kind of a take-home message in a few minutes from the both of you?
Sure. My take-home message really is that there should be hope. Therapy is a very effective way to approach this. And I mean that really regardless, okay, regardless of whether or not your child or your loved one really gets the kind of recovery that you might initially think of as a good recovery. Because therapy offers you a lot of different options. So I know that a lot of people are facing really what seems to be really devastating injuries. But the good news is that number one, there are, again, a lot of different mobility options out there. And a skilled therapist and skilled occupational and physical therapist and speech therapist can really help you and your child adapt well to really what seem to be devastating impairments. And can really help your child live a really good quality of life. And I think that that's really important to know. I also want people to remember that the body is remarkably adaptable, and that the message that we've talked about today is that you just have to keep at it. You have to keep working. And that, our bodies don't respond when we do something, 10 repetitions. It takes a lot more work than that. That it really takes good practice, optimum practice of a skill, and it takes really thousands and thousands and thousands of repetitions. I've got patients that really have made incredible, remarkable recoveries. Now, it may have taken them 2 years to see some of the improvements that they've seen, but they've just stayed with it and been patient and, had some ups and downs, but really had remarkable recoveries. So it takes persistence, and it really takes that team approach. You really have to become a team member with your physician and your therapist and work to get the best possible outcome. But I would say just don't give up. Keep at it. And you may have to adjust your expectations a little bit, but there's reason to hope. That would be my take-home message.
Yeah, I could not agree more. I think that I have seen some families keep a journal. And in this journal, they have where they started at let's just say square one, and then slowly but surely, as they write in their journal, they can see instead of going by hourly progress, but if they grade their progress week to week or even month to month, they can look back and see where they've been and just how much progress they've made over the last even 6 to 8 months. It is uplifting to see. Yes, it's uplifting, 100% uplifting to see how far you can come in a very short amount of time. Okay, Dr. Greenberg, any closing remarks from you?
Yeah, no, I'm glad you mentioned about the journal, because I was going to comment as Karen was speaking, and Karen's better at this than I am. The stories of patients who've been working at this a long time, and they have a frustrated day, and then you show them a video of where they started, and all of a sudden it comes home in terms of how much progress they're making. So I think those are good, very good and effective recommendations. I guess what I would say, which is probably one of the hardest things, is that every person and every family affected by this, I ask them to do two things which may seem mutually exclusive or counterintuitive. I ask for everybody to adapt to their current state of functioning, but do not accept it. People who have had a change in their neurologic function still need to go to school, still need to go to work, still need to do everything we have to do to be engaged in the world, whether it is with weak arms, weak legs, canes, crutches, wheelchairs, you name it. Those pieces of equipment and those changes in walking should not take us out of the world that we live in, and so we have to develop the skills to adapt. At the same time, we should not be adapting to the exclusion of working for improvement, and hence I say do not accept it. And there's a big difference between those two. The people who adapt but don't accept are going to school, going to work, being successful, but still doing the therapy such that they will be better a month later, 6 months later, a year later, you name it. And so there are going to be times when everybody is tired and everybody is frustrated, and the last thing in the world you want to do is the therapy you've been trained to do. But it's those times when you push yourself to do it that you are making a big difference in maintaining health and pursuing better health. So we're going to have, hopefully, lots of breakthroughs around AFM and TM. We're going to have a lot of science and a lot of new approaches to treatment, but they all take time, and they all take more time than we want them to. But do not wait on us to finish our job. There is a lot of work you can be doing, meaningful work, hard work, but meaningful work you can be doing to adapt and improve futures. So that would be my overarching message.
Yep, which is a great one. And I can't tell you how research comes into play. And it is hard work, it is meaningful work, but without the generosity of the families who work with us, I would not be able to give information and disseminate that information to other families and to physicians who are seeking answers and questions, and our nursing staff who are seeking answers and questions. And that is why I think the CAPTURE study, which is one way for families to be involved, it is, you are welcome to look it up in the Transverse Myelitis Association or myelitis.org website. And it's a questionnaire that we can have families answer: how well is your child doing at 3, 6, and 12 months after their diagnosis? But if you have a child who is school-aged, we would love, love, love to hear from them as well. It is the only, after 10 years of being in clinical research, it is the only study that I have worked with where we're asking children, how do you think you're doing? I think sometimes as doctors and nurses, we may guess, but it's been wonderful to hear their stories of recovery from their perspective. And if you would like information, please check us out at myelitis.org. Much appreciated. Okay, well, I want to thank both Dr. McCain and Dr. Greenberg for joining us today. It has been a wonderful discussion on acute flaccid myelitis. And I just want to let all of you know that we have the next TMA podcast is on November 21st from 1 to 2 Eastern Time. And our topic is on contraception, pregnancy, delivery, and childcare after a diagnosis of ADEM, or acute disseminated encephalomyelitis, NMOSD, or neuromyelitis optica spectrum disorder, and TM, transverse myelitis. Okay. Thank you both for being here today.
Thanks for having me.
Thank you. Thanks, Karen.
Thanks, Ben.